Lonkar. Sir is an associate professor at the NKP Salvi Institute of Medical Sciences in Nagpur. He's a consultant radiologist at Nidan Imaging Clinic. He's a chairman of the Maharashtra College of Radiology and the past president of MSB IRA. Thank you so much for joining us, sir, and over to you. So you can start your screen share, please. Dr. Prashant, sir, can you unmute yourself? We can't hear you.
Hello.
Yes,
Am I audible?
yes, sir, we can hear you. So can you start the screen share?
Yeah, I'm just starting it.
Yes. So once you click on the screen share, a box saying entire screen opens up. Just click on the center of that box and then the share button will turn blue.
Yeah.
Yes.
Can you see the screen?
Yes, sir.
Yeah.
Can you load your PPT, please?
You can see the PPT?
Yes, sir.
Okay. First of all, let me thank Kalyan chapter of MSBRI for inviting me today for this non-academic but equally important topic. When Prashant called me a couple of days ago, he was interested in PCP unity related things. So I just suggested him that yes, PCP unity is equally important, and since so many years we have been listening about PCP unity and the rules and the regulations and other things. But as we have seen, the radiology has evolved right from basic ultrasound to advanced ultrasound with great resolution machines, and that is true in all other modalities also, CT or MR. And while the machines are giving a lot of information to us, as a radiologist, we need to pick them up and report. While CT and MR are called static investigations, ultrasound is very dynamic. Sorry. And the image interpretation may differ person to person. So let us come to the topic. Recently, one of our Maharashtra group had one discussion. One radiologist saw a ANC patient with 20 weeks gestation. There was an excellent long section of the lower spine. He reported it as normal. Same patient came for repeat follow-up ultrasound at 13 weeks, and he saw just some irregularity at the sacral vertebrae, but the overlying skin was intact. So he reported that, and he said it's normal. On delivery, there was a sacral meningocele. He was worried whether there would be medical legal issue, whether there will be court case and all that. In another scenario, another radiologist, he found that the fetus is having a persistent posterior spine, and he couldn't see the skin and other overlying tissue. The only point in his examination was the cisterna magna was obliterated. So he had a suspicion that there might be some spinal cord anomaly. Then he asked for a follow-up scan. He talked with the patient, he talked with the gynecologist, and the patient came next day for a follow-up scan. And now the baby had turned, the spine was anterior, and he could see a cervical meningomyelocele. He was relieved and saved from a future litigation or future medical legal issue. Another scenario, ultrasound was done at 6 months of gestation age. The radiologist issued a report with a statement below his sign that no sonographically detected congenital anomaly. Unfortunately, the child was born with absent forearm. The case went into consumer court. The consumer court said that the statement of the radiologist That means that the fetus was normal and he was slapped a fine of 5 lakh rupees. One more scenario, at 32 weeks of pregnancy, ultrasound was reported as 32 weeks 01 day maturity plus minus 2 weeks with severe oligohydramnios. And in the text of the report, it was written fetal spine, trunk and limbs are normal. And this fetus also had absent upper limb on delivery. Quote unquote again slab fine for the radiologist. The last scenario, at least 6 ultrasounds were done in a pregnancy. The neonate had few absent fingers. The news came in the press that the baby is born without fingers and with the name of the radiologist also. The journalists, as usual, they take opinion from various people. They took opinion from 2, 3 senior radiologists. Some said it can be detected in first trimester, others said it can be missed, and at appropriate age they should be seen. The case is pending in the court of law. So, what are the points we take from all this scenario? First, there could be non-detection of anomaly till advanced age, even if position is okay. There could be no detection of the anomaly due to fetal position, that is improper position we can call it. Third, wrong statement can land up you in trouble, like so no sonographically detectable anomaly seen. Fourth is in in view of oligohydramnios, to put a statement that limbs and other things are normal is a potentially wrong statement on the part of radiologist. And lastly, probably there was lack of protocol while doing ultrasound. As a as I'm working in MSBRI, frequently people call for certain help for certain issues. One of our member called that he had booked a machine, ultrasound machine worth 20 lakhs, paid a 5 lakh advance to a company. Somehow the land deal could not be processed. There were some legal issues, and he cancelled order and he abandoned the idea of having a own clinic. So he did not buy any other machine also. So he wanted refund from that company. The company flatly refused, stating that refund is not possible as per the signed document. Still, he is not getting his money back. We have also written to the company, but company said whenever he buys a machine, we will give that much discount. But as our policy or whatever document we have signed, that is, there is no clause of refunding the advance amount. So the point taken here is the signed documents can protect the seller or in our case the service provider. Similarly, mutual funds, loans, we sign lot of disclaimers, lot of conditions, force majeure clauses, etc., etc. Do we think of prosecuting them? No, we don't, because we are informed about all of them. Or we know that we have signed the document. We may not have read those written in the smaller font, but we do not think of prosecuting them. So, coming to the medical malpractice cases, what are the causes of medical malpractice cases? Various studies show that it is usually the inadequate communication between the doctor and patient. Let it be a clinician, let it be a radiologist, let it be any other pathologist. So, from a legal viewpoint, what is required is the healthcare practitioner should counsel the patient regarding the benefits, limitations, and get us something in written. You can call it disclaimer, you can call it consent prior to the study. Practically, the counseling is not possible in actual practice. Let it be a government hospital, let it be a corporate hospital, let it be your own private practice. You cannot talk with a patient for 10-15 minutes explaining everything about ultrasound. One more study I could find in a medical legal journal. They studied 100 cases related to obstetric imaging. And the results of the study were there were three type of issues there. Allegation of underreported diagnosis. There was allegation of inaccurate fetal biometry, that the baby was born this much weight and this much gestation age, and that was given not improperly or incorrectly in the report, and misdiagnosis of fetal abnormalities. So this study concluded that the meticulous fetal biometry should be measured, diagnostic criteria should be followed, and there has to be some communication technique between the patient and the doctor, and there has to be proper documentation. Coming to obstetric ultrasound as such, we know it is most widely practiced. We cannot think of a obstetric practice without ultrasound. It is done in large number at most of the places, hospitals, clinics, everywhere. Practically, unlike any other ultrasound, this is a whole body scan. We scan the fetus in 10-20 minutes as per the need. Whereas other ultrasounds like abdomen, neck, MSK, Doppler, we study only that particular body part. So to study a fetus from head to toe within 10-20 minutes, we need protocols, and in case there are issues, we need some support or some shelter from certain medical level issues. And patients and obstetricians, they are well read thanks to Google, and they expect all is well answer. Many a times patient is sent with a note or with a advice to the given to the patient by the obstetrician that you get ultrasound done, they will tell everything is normal, then we can continue further. So what we should do? First, we should not raise expectation to unreasonable levels. To a reasonable level, to a level which is accepted by the literature, yes, okay. But we should not raise further. Among us, there are few individuals who are exceptional, but most of us are average. And we should not create a situation where promises made by exceptional ones become the nemesis for the average ones. This is important for majority of the practitioners, I am saying. So there has time come when we should start writing rather than conditions apply, rather than clinical correlation is suggested. We should start writing conditions apply or subject to reporting conditions or subject to conditions of reporting. You can use terms as you like. Because the scenario here is courts also consider every scan as an anomaly scan, and there are no government body guidelines in India. Even IRA, ICRA does not have guidelines on this issue that would help us in case that there are some issues. And typically, as an Indian radiologist, including me, we are hesitant to use consents and patient information sheets for ultrasound as such. We do use consents for IVU, we do for biopsies, FNSCs, and invasive procedures. But for a non-invasive procedure like ultrasound, we are hesitant to use them. And the over expectation, as I said, frequently results in litigations. And then comes the fear of medical legal claims and other things. And ought to know, we ought to make it clear that no science is perfect. This has to be for us, for the obstetrician, for the patients. Friends, we are facing this pandemic since March, and we are using masks to reduce the risk of getting infected. It does not eliminate the risk of getting infected. People have got infected after using complete PPE kits. Similarly, the disclaimers, they are required to reduce the risk of getting prosecuted. It is not a complete legal, what you can say, legal barrier against a barrier against any legal issue. So what is communication means? Communication is giving correct information. We can give it in verbal, but because it is not possible, we can give it in writing. What the communication should have, it should have the risk of the investigation, benefits from the investigation, and importantly, limitations of the investigations. And again, advantages over other investigation if there are. So you can call it consent, you can call it disclaimer, you can call it conditions of reporting. As I said, this disclaimer doesn't give us a complete immunity against legal proceedings. But what it does, it minimizes the misconceptions among the patient and also the obstetricians, and acts as a mental barrier against the blame game. Same barrier as we see when we have any service issues with a bank or any other organization. Even a case is won or lost eventually if something happens and the patient goes to the court. The mental stress and humiliation, the infamity we get is very enormous. And even if the patient doesn't go into the court, mental harassment is definitely significant. So, the disclaimer surely acts as a preventive step in this case. So, what a disclaimer should have? The disclaimer should have information basically about that investigation. If we think about ultrasound, what is ultrasound? Why it is done? What is its use? And what are the advantages? And what are the benefits? Risk, we know there are minimal with ultrasound. But importantly, limitations of ultrasound. Ultrasound is not 100%, we know it. So we should make the patient aware about the limitations and what the patient should expect from the investigation. And finally, what are the conditions of reporting. So with this aim to bring uniformity in interpretation of ultrasound reports, to achieve patient education, better communication and understanding of the patient, and informing them about the conditions of reporting, and as a support document in case of dispute or allegations. One more important aim was to achieve patient status for the specialized ultrasound nowadays we are doing, and to separate them from routine ultrasound, and finally to improve the practice standards of our fellow members. We, from the Maharashtra College of Radiology, which is an academic wing of MSBIRI, was established last year, and we formed a obstetric subspecialty group comprising 8 radiologists from across the Maharashtra. And we have just separated the NTNB, anomaly, vitiligo, and a routine scan or a growth scan into 4 types. And we have made certain common points and certain specific points for the investigation. I will tell you in brief. The common points, as many of us are writing, is identity and contact details as given by the patient, and the investigation has been done on the request of the referring doctor. And all measurements are subject to statistical variation. I think everybody is writing that. Importantly, ultrasound machine can make error in interpreting echoes and has limitations in diagnosing lesions. This needs to be told to the patient. Few more common points are limitations due to fetal factors and maternal factors. We have seen examples of fetal factors like position, amniotic fluid volume. Sometimes fetal movements, especially in fetal ego, can be an issue. Maternal factors, wall thickness, multiple pregnancy, they can be a limiting factors. So it is important to understand for the patient that every ultrasound in pregnancy cannot evaluate everything about the fetus. So as regards first trimester ultrasound or NT-NB scan, it is popularly called, we need to inform that this is to be done in this window period. We know that, obstetricians know that, but whether the patient knows that, patient comes for and gets a chit from the gynecologist at 13 weeks for doing a NT-NB scan and comes to you at 15 weeks. So in that situation, this can help us. We have to inform that this is a very highly specialized ultrasound, takes a good amount of time, gives additional information about certain parameters. And abnormality in these parameters can be indicative of chromosal anomalies, aneuploidies, etc. And certain anomalies cannot be diagnosed here, that has to be told, because especially for NT-NB scan, the gynecologist tells the patient, बच्चा पगला है कि नहीं देखने के लिए या बच्चे के ब्रेन में फॉल्ट है कि नहीं देखने के लिए NT-NB scan is to be done. Patient also comes with same conception that he has to see the mental status of the fetus. But we need to educate them, we need to inform them. Then every pregnancy has got a background risk of anomalies that we know, but patient should also know. Then further, in the first trimester ultrasound, a point is to calculate the risk of having fetus with chromosomal abnormality. We need to combine. It's not NT or MD The nasal bone absence is not 100% indicating of a chromosomal abnormality. It has to be combined with various serum biochemistry markers. And even after combination, if there is high risk, it doesn't mean that fetus is having the disease. The low risk doesn't mean everything is all is well. This has to be informed to the patient. And some abnormalities seen at the first trimester cannot be false positive indicators that we know them. Coming to the second trimester anomaly scan per se, as we do it between 18 to 22 weeks, sometimes patient comes at 28 weeks for the anomaly scan, especially when if you are serving a rural population or smaller towns. Then what we should write is we should write that each part of the fetal anatomy is examined to see that baby is developing normally. We give attention to certain things, brain, face, spine, etc. Heart, we have to inform that this is a basic evaluation of heart and this is not a dedicated fetal echo. Then other organs like stomach, bowel, kidneys, long bones, we pay special attention while doing fetal echo. But we have to inform that the counting of fingers and toes is not done. It's practically not possible. We can see the fetus with clenched fists. We can try to see them with open fists, but we don't count phalanges. Further, if we don't find any abnormalities on the scan, it is not a guarantee of a healthy child. It is not all or none, right? And there are some significant variability in the sensitivity of the routine ultrasound for detection of various fetal anomalies. So there can be false positives, there can be false negatives. And most importantly, this is not a final diagnosis, and this has to be correlated with the clinical history, a previous history, and other investigations like biochemistry investigations. At second trimester anomaly scan, certain anomalies like diaphragmatic hernia, hydrocephalus, microcephaly, club foot, obstetric anomalies, certain heart defects may not be seen. It is given in the literature. And also, some anomalies are at all not detectable by ultrasound. Whether the fetus will have MRCP in postnatal life, we don't know. And so we need to mention that there is best time to evaluate certain parameters or structures during pregnancy. Fetal echo is again a very highly specialized ultrasound, and a few more points we need to write that not all cardiac anomalies can be detected. The ability is limited by fetal and maternal factors as discussed. Few anomalies are evolving. They will evolve late in the pregnancy, and some are definitely postnatal diagnosis. And there are limitations due to patient coming late, say be more than 26 weeks, the equipment used, the experience of the radiologist, time constraints, and poor acoustic windows. So once you have done this specialized, separated this specialized ultrasounds, NTNB scan, anomaly scan, and fetal echo, what remains is a routine obstetric ultrasound. It's frequently referred by the obstetrician. We can call it as a growth scan, or we can call it as ultrasound done to in certain indication. For example, just to look at placental localization, or just a dating pregnancy, or just if patient is having leaking, to look for the amniotic fluid index, cervical length. So there are certain clinical situations where a detailed anatomical evaluation is not necessary. This may have been done before. This may have been done, may be required to be done after when the adequate period or the proper period for that investigation is done. There is a list of investigation we have prepared, and this we will be publishing very soon. And we are not the only one to doing this thing. The AIUM has already published their guidelines on limited obstetric ultrasound a couple of years back. So we know the literature is vast, and if you try to put everything in, it will be a big document. So we have made a single page format so that you can use in a day-to-day practice. The consent document has common points and specific points for the 3 to 4 or situations we have discussed. And we can give this page to the patient and get it signed before doing obstetric ultrasound. While waiting outside, patient can just read them and understand that they cannot expect 100% from the ultrasound. And the detailed documents, they are with references. There are some are 5 pages, some are 10 pages. We can get this printed and keep with us like we keep the PCP book, and then it can be given if the patient wants to know more details. And all these documents are available on our website of MSBIRI. And we hope these documents will be of great help to all of you in hassle-free working. And if there are some feedback, suggestions for improvement in the same, they are most welcome. The website of MSBIRI is www.msbiri.in. There is a tab called MCR, Maharashtra College of Radiology,